I think my time is over. Because I have a strong faith and strong belief that the most difficult job is to be honest. If you are honest to your own self, that is the most difficult job. And he has obviously given us the opportunity to be absolutely honest. So I will not go on and on, though I can speak on my favorite topic of robotic bariatric surgery for super obese for days and days, but I would definitely love to curtail my talk to allotted 20 minutes. I bring greetings from Institute of Minimal Access, Metabolic and Bariatric Surgery, Sir Gangaram Hospital, in which I have a strong faith and strong belief that this kind of surgery is a team effort. It is just riding the Formula 1 racing car, and if any of the team members is saying, sorry sir, I could not fuel the car, or I could not fit the bolt in the tire of the car, all of us know the result will be a fatal result. So I am very, very clear that together everyone achieves more, TEAM. So one has to work, and one has to work on a team, then only you can deliver these results. I am not going to speak about the basics of robotic surgery. Dr. Mishra just now told me that you had the witness to see the robotic sleeve gastrectomy yesterday and robotic hernia today. So that job is definitely simplified. And now I am going to present focused talk on robotic bariatric surgery. Why did we focus on robotic bariatric surgery? Is because of these kind of abdomens. When these kind of abdomens of the weight of 200 kg or 240 kg, 270 kg, when they come to us, we definitely offer them the robotic bariatric surgery rather than laparoscopic bariatric surgery. We have been doing laparoscopic bariatric surgery for quite a long time. We do sleeve gastrectomies, gastric bypasses, but our feeling is that these kind of abdomens, because of the depth of around 10 inches of the abdominal wall, lot of torque is there on the rigid instrumentation. When we are using the laparoscopic straight instruments, though they are 45 centimeter long, still the torque is there, and when we are operating at the angle of his, and when we do the stapling and when we do the oversewing of the staple line, we are not at all comfortable with abdomens of 10 inches of 270 kg patients. So when these kind of patients, super obese patients, 83, 84 BMIs, when they come to us, we offer them robotic bariatric surgery rather than the laparoscopic surgery. Now, what is morbid obesity? Not going into the details, but definitely the super obesity is when we have a BMI more than 50, and super obesity is when the BMI is more than 60. Why robotic surgery? As I mentioned, that because of the advantage of the wristed movements of the robotic surgery, that we have the ease, and the surgeon is absolutely comfortable when he is operating and sitting on a console in such kind of abdomens. That is the reason that we offer robotic surgery. Why robotic sleeve gastrectomy? All of us know the word over. Now the trend is, as Dr. Chauhan was also telling, that I am a frequent visitor, or I love traveling. So once we go outside and once we attend the ASMBS conferences in US or anywhere, if so conferences, we realize that in last few years, maybe when we started our bariatric surgery in 2000, we were doing the bypasses. Definitely sleeve gastrectomy was being practiced more in India rather than outside in US or UK. But now the trend has totally changed. Most of the hospitals, even in US, who were doing lot of the bariatric work and lot of bypasses, now switched over to the sleeve gastrectomy because of the results. The results of sleeve gastrectomy vis-a-vis bypass are more or less similar as regard to even the metabolic component. The weight loss component is definitely there. The metabolic component also has more or less similar results at the end of 3 years, and that is why most of the surgeons, most of the bariatric surgeons are shifting themselves from bypasses to sleeve gastrectomies. And why? What is the indication of doing the gastric bypass? We do gastric bypass in those kind of patients in which the BMI is more than 45 and they are having comorbidities, for example, uncontrolled diabetes, hypertension, joint pain, sleep apnea syndrome, and so on and so forth, so that ultimately their diabetes resolution is faster. Though the diabetes resolution is there with the sleeve gastrectomy also, but it is faster with the robotic or with the laparoscopic gastric bypass. And it has been realized that once the surgeon is comfortable sitting on the console, maybe he is doing surgery for 4 hours or 5 hours or 7 hours, but if the revisional bariatric surgery has to be done, if the endo suturing has to be done with the endo-wristed movements, it becomes very, very easy. As if we are operating on a patient of sitting or inside the abdomen, and the suturing becomes very easy as if we are doing the open surgery suturing. And the complications also we will dwell at the end. Now, why robotic surgery? All of us know, you have seen also the biggest advantage is that it is 3-dimensional image rather than 2-dimensional image of the laparoscopic surgery. One. Second is that 7 degrees of freedom is there, and another aspect is why did I choose robotic surgery is that I want to operate till the age of 89 or 90. So that even if I have the Parkinsonism, even if I have the tremors, but the scaling of the tremors can be done on the console and it will not be having any change in the outcome on the patient. That means it scales, the robotic surgery scales the tremors, and then ultimately it is a consistent outcome which we are going to get in robotic surgery, and it has been seen that definitely in bariatric surgery it has a major role. Now can you imagine, I am just exemplifying this. This is a patient of 84 BMI. When she came to the casualty, she came with a respiratory arrest. And it was a very, all of us know that when these kind of patients come in casualty, they have a respiratory arrest, intubation definitely becomes very, very difficult, but with all the teamwork, we could intubate her, put her on ventilator, optimized her for 7 days, and then we took her for robotic bariatric surgery. And once we take these kind of patients for robotic surgery, definitely the challenges are there about the positioning of the patient, about the table of the position, but these challenges are minimized by the robotic arms. So these robotic arms act as cranes and they lift the 10 inches of the anterior abdominal wall up, and then we are able to do the stapling and suturing in as easy as possible sitting onto the console. And now can you imagine, this patient, she was 193 kg to start with, she came in respiratory arrest, and now she is 93 kg and she runs. And ultimately advantage is that whole of the confidence changes, the mindset changes, and these are the advantages which ultimately we offer to the patients. And as I mentioned, that this robotic surgery offers a stable kind of platform. And if it is a prolonged kind of surgery, the surgeon can sit onto the console and then definitely helps. And one is able to do the difficult surgeries also with robotic surgery rather than with laparoscopic surgery. Cost. Most of the times, most of the objections from the surgeons are that it is the cost that patient is not able to, will not be able to give. But please tell me, cost is only a relative phenomenon. It is not an absolute phenomenon. For such kind of lady, if I had done a laparoscopic sleeve gastrectomy, I may or may not have taken that patient because of the difficulties which I would get when I am doing the laparoscopic surgery. But if any of these kinds of Formula 1 racing car goes bad or goes wrong, or if the leak occurs, then the cost of managing that kind of leak is tremendous. So our mindset is very, very clear that surgeon has to be convinced from within that this cost is definitely reasonable and it is a relative phenomenon rather than an absolute phenomenon. One should always think of the complications, one should always think of the limitations in the mind, and ultimately we are able to justify that. Learning curve, I will substantiate it with lot of papers later on. That learning curve is not much in the sense that if you have been doing laparoscopic surgery, if you have been doing open surgery, if you start sitting on the console, it does not take much time to get tuned to sitting onto the computer and then working because of the mindset. And it is when we do the sleeve gastrectomy, we always believe on giving a uniform kind of stapling line. So staplers now, can you imagine that after the advancement, I am not saying that the final word has been written yet, but the advancement is going on and on. Now the Da Vinci system has come out with the stapling devices which can be fired by the surgeon sitting on the console rather than taking the advantage of the patient or the surgeon who is standing by the patient's side. So why sleeve gastrectomy? That ultimately the result is excellent. And when we take these kind of patients, super obese patients, we have to be very, very clear that the table should be such that it is not going to give way. I know of the instances when these morbid obese patients or super morbid obese patients are placed on the table, even the table can drop down. So one has to be very, very careful. One. Second thing is that one has to fix these kind of attachments laterally so that ultimately the patients, the first and the foremost thought process is failure is not an option. For these kind of Formula 1 racing car, failure is not an option. So one has to be very, very careful that we take care of the DVT, we take care of all the parameters, and then we place the patient and we take care of the stirrups so that the pressure effects are not there. When we place these patients on the OT table, only, I would say, drawback in the mind when we were shifting from laparoscopy to robotic surgery is that there will be only one time docking. One cannot go on docking and undocking every time. We have to change the position. So in this kind of position, in this kind of patient, we have to make sure that the patient is head up, the rise tube is placed in, the suction is done, gastric emptying is done, and then we ask the anesthetist to put in the bougie also. When we place the bougie and when we will be directing while doing the robotic surgery, then we always request the anesthetist to place in the bougie in such a manner that it transgresses the pylorus and ultimately goes into the first part of the duodenum. As soon as it goes into the first part of the duodenum, the bougie is going to stay close to the lesser curvature rather than close to the greater curvature. And once it is close to the lesser curvature, the firing, the stapling will be in a uniform, consistent manner, and ultimately we have to just request our anesthetist to pass in the bougie. Once he reaches this area of pylorus, then we ask them to just give a twist to the tip of the bougie, and there is an orgasmic feeling so that ultimately it goes into the pylorus and into the duodenum and it stays there. So that ultimately helps us. And we have to make sure that the position is done nicely. In the initial phase of the learning curve, we were placing the robotic cart from the left shoulder. But ultimately we realized that if we place the cart, that means 3 arms, from the head end, the robotic cart time or docking time definitely decreases. And now we are placing the cart all from the head end, and believe me, in laparoscopic surgery, the port placement is very, very important, but it is far, far more important in robotic surgery that how are we going to place our ports at a distance of around at least 8 centimeters from each other so that the clashing of the instrumentation is not there. Most of the times, if it is a new surgeon, then the clashing of the instrumentation is there and it becomes a difficult proposition. As I mentioned that, for example, the docking time also decreases once it goes into the system. Every and any time the systems have to work rather than the surgeons or rather than the leader has to work. Our philosophy is that once the team is geared up, then we ask our OT technicians to drape the robotic arms, and initially it used to take around 20 minutes. Now we are able to drape and dock in just 3 minutes. So it is a mindset rather than anything else. And once the draping is done, and then we dock the card, and then we place these cards, one has to get the training done, but it does not take much time. Our feeling is that once we are able to do maybe 20 cases, we are absolutely comfortable. Initially, when I started doing the robotic, I converted myself from laparoscopic to robotic sleeve gastrectomy. The steps of the sleeve gastrectomy are the same. That we measure from pylorus and we go and leave 5 centimeters, but we fire the staplers, and then once the stapling is fired, then we start the oversewing of the staple line. We strongly believe on oversewing the staple line, but there are surgeons who believe only on stapling and not using these. We are not using the seam guard, we are just oversewing it, and oversewing definitely is easy proposition when we are doing the robotic surgery. And our philosophy of thinking is it has to be standardized, so that once we are able to do it, then our fellows are also able to do it in the same manner, and ultimately the results are excellent. And we always believe on doing the check endoscopy, and most of the times, thanks to our anesthetist, that when we do this robotic surgery, and that to a patient of 278 kg, now he is able to shift himself out of the OT table. We strongly believe on extubation on the table and take the patient onto the trolley just by himself, rather than relying. We have got the patient pad slides and whatnot, but we believe that the patient should, because most of the time these kind of patients can have respiratory problems, respiratory arrest, or afterwards if the reversal is not adequate. So one has to see the whole of the program rather than just the whole of the patients. My feeling is that ultimately it is more important to develop a team and to develop the program so that the results are the best. And then these kind of patients, we always strongly believe on mobilizing them as early as possible. After maybe 4 hours we have mobilized, and after 24 hours any and every patient of robotic bariatric surgery is able to move around, and that ultimately becomes an advantage for this kind of surgery. Initial learning curve, as I mentioned, in robotic sleeve gastrectomy, you have to do around 20 cases to get used to do the robotic surgery. I must share you my ignorance or my initial phase. I was doing the robotic sleeve gastrectomy. Though we had started doing the robotic cholecystectomy 1 case, robotic hernia 1 case, ventral hernia 1 case, and then we shifted ourselves to advanced cases. What I mean to say that I am not selling the robotic cholecystectomy or robotic hernias. Our thinking is that access the inaccessible. In those situations in which the laparoscopic surgery is not comfortable, then only we are offering the robotic surgery. Robotic cholecystectomy is not going to replace all the laparoscopic cholecystectomies, believe me that. Now I was doing the robotic sleeve gastrectomy, and can you imagine when I was manipulating with my arm, with my fingers, then one of my hand was this, and another hand was when I was sitting on the console, and I carried on operating, and I was thinking that why people say that there is not much of strain on the shoulder or onto the elbow, but I am having a lot of stress. Then the person from Da Vinci, he came and he said, "Sir, just press the clutch and come back to normal." And I just pressed the clutch, and then I realized that it was such a simple thing. So what I mean to say, getting used to a new computer, getting used to a new equipment, it definitely takes some time, but do not please think that it takes a lot of time. Even if you have not been doing laparoscopic surgery, even if you have been trained as an open surgeon, still if you are going in for robotic surgery, it definitely is a good proposition. And all of us have seen that docking time also comes down, even the operating time. Most of the times in such kind of meetings, objection was, how much time are you taking for sleeve gastrectomy? Initially, yes, we used to take around 2.5 to 3 hours for doing the sleeve gastrectomy, but now that time has come out to be 1 hour, just 1 hour or 1 hour 10 minutes. So it is a matter of practice, it is a matter of team effort that ultimately these kind of surgeries give the benefit to the patients. I know that the literature has come and it is showing that definitely it is advantages. And I had the opportunity to visit Professor Giulianati in University of Illinois at Chicago many times. Can you imagine that he is doing the robotic Whipple surgery in just 4 hours? robotic or totally robotic vehicles in just 4 hours. So it is matter of doing it again and again. And they have done the comparison of robotic versus laparoscopic sleeve gastrectomy, and it has been found that ultimately the outcomes are better with the robotic surgery as compared to the robotic surgery, one. And second thing is, as regard the time, now you can see that in robotic surgery it was 135 minutes, whereas in laparoscopic surgery 114 minutes, whereas in laparoscopic surgery they had not done the suturing of the staple line, and in robotic surgery they have done the oversewing of all the staple lines. So even if the staple line suturing has been added, still the time difference is not much. So that is the advantage of doing the sleeve gastrectomy by robotic method. But only in those kind of situations. I am not going into these kind of videos are available on our website, on YouTube also. But definitely, if these kind of patients, once they are getting the surgery done, on next very day, if they are moving around, that ultimately changes the confidence of the patient, that changes the confidence of the relatives, and that is the reason that we get lot of these kind of super obese patients. Now, why gastric bypass? As I mentioned that I had an opportunity to visit Keith Kim. Keith Kim is a surgeon who is doing 7 to 8 robotic gastric bypasses every day. Initially, I also used to think that gastric bypass will take slightly longer time as compared to sleeve gastrectomy, but once it comes into a system, then it takes just 1 hour and the robotic gastric bypass can be completed. And the advantage of going to these kind of people who are doing lot of work is that one can sit onto the console. They have got the console on which the surgeon is sitting, and I am sitting onto the side console, and I am able to have a similar 3-dimensional binocular vision as the surgeon is having, so that and if the surgeon wants, then he can let me do the suturing or anything, so that ultimately it becomes easy for the surgeon to learn. It is learning. Robotic surgery is easier for the surgeon as compared to even laparoscopic surgery. And it has been seen that if we do the laparoscopy versus robotic gastric bypass comparison, that it has been realized that once we do the gastrojejunostomy and once you do the hands-on gastrojejunostomy, the complication rates are definitely less. It has been reported that if we compare the laparoscopic anastomotic leak compared to robotic anastomotic leak, definitely in laparoscopic leaks are more. Similarly, the stricture formation is definitely more, and it is just because of the precision. And because the precision is there, because we are now relying more on hand-sewn technique rather than on a stapling technique, so it becomes easier, it becomes 3-dimensional view, and that ultimately gives the advantage, and the patients do not have any failures. If the failures are there, obviously one will have to go back and then convert it to laparoscopic surgery, and if still one is not able to manage, then one can convert to open surgery. But one should be trained and one should know, and it is a good armamentarium in the addition of the bariatric surgeon. And again and again I am emphasizing, I am not going into the details of it, but definitely one should lay a lot of stress on the port placement for the gastric bypasses. And as I mentioned, that when we do the hand-sewn gastrojejunostomy, definitely it becomes easier. The results are far more better as compared to the stapling anastomosis. Now, the advantage of the innovations are, now for example, harmonic AS is also available, which can always take care of the gastrolysis or dissection, and then one is able to fire the staplers also, as I mentioned. Now these are available, and one is able to do the suturing in a perfect manner. So this is the advantage that definitely helps the patient in totality. And only thing is that initially, as I mentioned, that we were also thinking that in gastric bypass, because we have to work in a supracolic compartment and then infracolic compartment, and then I will have to change the position of the docking and the patient and the robotic arms. But no, if we are placing the patient in head-up position right at the beginning, and then we are standardizing our steps, then definitely there is no need of changing the position again and again, and we are able to ultimately deliver the best to the patient. There is a comparison of robotic gastric bypass versus in super obese patients, and the results are excellent in all the studies or many of the studies. But definitely I would say that it is the mindset, one has to train oneself and never ever believe on excusitis. Most of us, I strongly believe on that, most of us suffer from excusitis. We do not have the access to robot, and then we start saying robotic surgery is bad, it should never be done, it is too costly an affair. But if you have a mindset that yes, the problems are there, the challenges are there, they have to be overcome, and you are responsible for what you have, and you are responsible for what you don't have. Thank you very much for your attention. Thanks a lot. Any questions?
We can have the lights on so that we can see that if delegates in any questions. Please put the lights on.
Yes, sir.
Put the lights on, please. Somebody.
Regarding the distal point of the second case,
Please give the mic.
6 cm from proximal to the pylorus. Some surgeons say only 4 cm. Some surgeons say it is depend on the patient. It is variable. It is not fixed point.
Wonderful question. Question is that is there any agreement whether the pylorus has to be left or not, enterectomy has to be done or not, or if it has to be done, then approximately 4 centimeters proximal to the pylorus, or 5 centimeter, or 6 centimeter, or 7 centimeter. Our feeling is also similar as you have, but our thought process is that we have standardized to 5 centimeters. We know there are surgeons who are leaving just 2 centimeters, and we know the surgeons who are doing 7 centimeters. We have taken a moderate path, and you cannot manage what you cannot measure. Our thought process is that we, as you saw, that we put in a umbilical tape inside of 5 centimeter and exactly measure from the pylorus. It is in the initial phase, he is absolutely right. In the initial phase, we did not come to know that where is the pylorus, what is the exact point at which the pylorus is there. So one has to identify the pylorus by pre-pyloric vein of Mayo, by seeing the change in the color of the stomach as well as the duodenum. There is a transition, definitely transition is there. One can see the veins which are reaching just close to the pyloric antrum, so one has to be very, very careful. And if you are able to measure by 5 centimeters and then do the gastrolysis 5 centimeters to the angle of phase, and then when we are firing the first stapler, we are, as I mentioned, we always make it a point that we are not too snug to the bougie and not too far off from the bougie, so that the volume of the pylorus which we are leaving behind is not more than 20-25 ml. So these are the small steps which we feel that ultimately affect the weight loss and the metabolic changes. Yes, sir.
The idea is to avoid stenotic area in this region, in addition to avoid injury to nerve of lateral jets.
Exactly.
And trunk bump.
True. We fully agree with you. It is not the commonest site of leak of sleeve at the angle of face. It is not the culprit. 70% of the leaks would occur at the angle of face. It is not the culprit. We should never be only after the leak site, but one should always be bothered about the pyloric stricture or pyloric stenosis. If we have gone too close to the bougie, if we have left too small a pylorus, and if we have caused a stricture in the first green firing, the chances are that the distalmost point, the weakest point, the avascular point of angle of his will leak. So never ever treat the leak of angle of his. Always think in the back of mind that it is the pyloric stenosis which is responsible for the leak. Excellent point. Thank you, sir. Wonderful.
Focused. The only thing I would like to ask before the other delegates come on with it, you said there is a definite advantage as far as leak or stricture is concerned when you're doing it robotically. Why not do it the same procedure in the not super obese? If that advantage is there, why not pass it on?
Wonderful question. The robotic surgery for non-super obese patients. I am not saying that. I am saying that if one has to select the patient, for example, now today, if the patient of 40 BMI comes to me I always tell them both the techniques. I always tell them there is one method called as laparoscopic surgery. If you can afford, it is 1 lakh rupees extra, and you will have to, and we can do robotically. And believe me, most of the times, most of the patients agree to me for getting the robotic surgery done rather than laparoscopic surgery. But on those situations in which the BMI is 83, 84, 90, we have those kind of patients. Once we get, I had the opportunity to present our work in Washington DC last month, and when we presented our work, even the surgeons in US were surprised that why are you taking so many challenges of tackling 83 or 85 or 90 BMI patients. Our thought process is that these are the patients who are getting the maximum advantage of robotic surgery, but nobody excludes us to travel from Gurgaon to New Delhi by Mercedes or BMW. Why take only Corolla?
Any other questions from the delegates?
Sir, I think at the Sir Gangaram Hospital, probably we are doing the largest number of cases with robotic as compared to other institute. And Dr. Bhatia is also running his own institute with the name of Bhatia Global Hospital. And I again thank you, sir, personally from my side for having spare time. Thank you very much, sir.
Thank you very much. Let me take this opportunity to invite you all anytime to Gangaram Hospital to watch the robotic surgery. We are going April 15th and 16th, where we have invited Professor Julunati and Professor Ali from University of Illinois at Chicago. So you are more than welcome to see the cases. Workshop will be there, plus lectures will be there. You are more than welcome. Thank you very much.
Thank you, sir, to our participants and to our students also. Thank you very much, sir, once again. And now I will request our other speaker, Dr. Radha Krishna. Dr. Radha Krishna is another very, very senior consultant surgical gastroenterologist from Apollo, Chennai. And Dr. Radha Krishna has been very kind enough, and he is always associated with our World Congresses. This is our 4th World Congress, and he has been regular visitor to our conference. And now Dr. Radha Krishna is speaking on day care laparoscopic surgery. I know that in the audience we have, most of us are laparoscopic surgeons, and our bread and butter is laparoscopy and not robotic. So we have much more to learn from Dr. Radha Krishna also. And one question I wanted to ask from Dr. Praveen Bhatia, sir.
Yeah.
It just struck me now that everybody says, because of the cost constraints, robotic is not going to be universally available. When do you expect that the cost will come down and the penetration of the robot will be much more? Like every time we keep on listening that the patents of intuitive surgical are going to expire, some new system are going to come. Can we have a mic, sir? With the...
Definitely, I would answer this by saying that in the initial phase, I remember when I came back from US, and I was the first one to buy the mobile phone. And when I bought the mobile phone in December 95, then all the surgeons, all the doctors were having the pager, and they opposed it. Why are you going in for such a costly equipment, costly instrument, when the incoming call is also 32 rupees per minute and so on and so forth. But now all of us know that what is the cost of the mobile phone. Even our sweeper or even our bot boy or anyone and everyone is having the mobile phone. So I think the more the number of surgeons use the robotic facility, definitely the cost will come down. And again, cost is only a mindset. There are people who want the best, and believe me, these kind of super obese patients or obese patients, once we give them the choice, once they also realize that the surgeon will be absolutely comfortable and he is able to give the result in the perfect manner, they go in for robotic surgery. And regarding the patency, I must clear, and I am going to speak in a similar kind of topic in Robotic Council of India. I am the active member of Robotic Council of India, and today we have a conference in Radisson Hotel. After this, I am just going to deliver the talk there. But believe me, the patency issue is just a myth. Because the Da Vinci has taken a patency of equipment of the robotic surgery, so it is not going to change. Only thing is that once the competition builds up, they will have to reduce the cost.
Definitely, sir. Because, sir, this I want to share it with you. Like we have got a robotic training program also.